Hello and welcome. My name is Jessica Adelman. I work in social media and communications for the Ehlers-Danlos Society, and I will be your moderator today. For our webinar today, we have Dr. Ann Maitland presenting on Mast Cell Activation Syndrome, More Than Just Allergies. This webinar is part of our ongoing series, Living with EDS and HSD. A quick note about how this webinar is going to work. Attendees are muted at all times. However, you may type questions into the question box at any time. Dr. Maitland will not be able to see or respond to any questions until the Q&A time at the end of her presentation. Please do not send your questions more than once, as it will not increase the chance your question will be answered. It will only make it harder for us to sift through these questions. This webinar is being recorded and will be posted on our website and YouTube page early next week. Dr. Maitland has been named one of New York Times super doctors since 2011 and one of America's top 21 women's doctors by LifeScript.com in 2009. She is a fellow of the American College of Allergy, Asthma, and Immunology and a member of the American Academy of Allergy, Asthma, and Immunology. Dr. Maitland is active in local societies and the surrounding communities to increase awareness of immune-mediated disorders, including primary immune deficiency and mast cell disorders. She is also involved with research to continually improve the treatments of classic allergic disorders and recurrent infections. Her clinical focus includes the diagnosis and treatment of allergic skin disorders, allergic rhinitis, drug allergies, food allergy sensitivities, asthma, and recurrent infection. Dr. Maitland is currently an assistant professor in the Division of Allergy and Clinical Immunology at Icahn School of Medicine at Mount Sinai, New York, and the medical director of comprehensive allergy and asthma care in Eastchester and Tarrytown, New York, as well as an attending physician at Phelps Memorial Hospital in Sleepy Hollow, New York. Thank you so much for being here, Dr. Maitland.
Well, thank you for that wonderful introduction. I'm going to try to live up to this, and we're going to talk about a cell that really has gotten very little attention until the past few years, and how this might be contributing to hypersensitivity reactions, whether you have a positive allergy test or not. So let's talk about this little pink cell that has lots of different sacs that sits in every single organ system, and that's called the mast cell. So briefly, there's been a lot of associations with individuals that have dysautonomia and postural orthostatic tachycardia syndrome, and people usually get diagnosed with this criteria, especially when you stand up and then your heart rate just zips past 30 beats per minute. But what has been interesting is that individuals that have dysautonomia, which can also be associated with Ehlers-Danlos syndrome or hypermobile spectrum disorder, is that they have lots of different symptoms that overlap that which occurs with individuals that have mast cell dysfunction. So you can have upper airway issues regarding congestion, throat tightness, headaches. You can end up with chest pain and shortness of breath. Definitely a lot of gastrointestinal distress, urinary tract issues, skin issues, especially flushing or itching, and then also pain syndromes as well. And what's interesting with a lot of the patients is that they also end up with increased heightened smell, and which can cause headache disorders as well. And so as an allergy immunology specialist, I became involved with individuals that have connective tissue disorders, which can also be associated with having autonomic dysfunction, because that cell that you see at the top left corner sits in the connective tissue. The connective tissue influences the mast cell function, and then the mast cell function in turn can influence how the connective tissue is functioning as well. So a few years ago, I started receiving referrals from neurologists as well as neurosurgeons, because it seems that if you use medications that targeted a classic allergy cells, patients thought that some of their symptoms would improve. And then also I started to see patients who were starting to have allergic-like reactions to foods or airborne chemicals and smells and medications where the allergy testing would not explain why they were having those issues. And then what would be really interesting is that the individuals that either were suspected to having mast cell disorders or dysautonomia typically would have little things along the way, but then something would cause them to get worse, whether it was an environmental exposure, especially, for instance, mold, either in the home or workplace, an infection, a motor vehicle accident, a surgical procedure, something that just opened up the airway, opened up the Pandora's box. And they would have neurocognitive issues, headaches, trouble remembering. They would have cardiovascular issues with their heart rate being very labile or blood pressure, palpitations, joint pain, urinary tract issues. And unfortunately, the way healthcare works, we all have a tendency to kind of go to the specialist that would address that particular organ system's problems, but it really does require somebody who takes a step back and tries to understand that it is the communication of the mast cells with the nerve fibers right next door that may be influencing why someone is so unwell. So let's talk a little bit about the mast cell. This was a cell that was originally identified back in the 1800s and found in organisms that didn't have antibodies. So clearly these cells can be activated in ways other than having a positive allergy test. Mast Cell Activation Syndrome was originally coined back in 2010, and the definition for someone that has mast cell activation and then has possibly mast cell activation syndrome is as follows. So we know that mast cells can be activated for lots of different reasons, and they have a job to do besides going after pollen or mold or penicillin. They participate in tissue repair. They participate in defense against certain organisms. And depending on what these cells see and what location of the body, they can release different chemicals depending on what they feel they need to meet the needs of that particular situation. So someone who has mast cell activation syndrome, meaning that the mast cells are now being overactive outside of what they were originally called to do, is defined as someone who has symptoms that are recurrent and involving at least two or more organ systems, that you can actually detect increased mast cell activity either by chemicals that we know that they release, such as tryptase or histamine, and that they respond to medications that will cause the mast cells or the mediators to quiet down. And the classic ones are histamine blockers, such as diphenhydramine or hydroxyzine. So this is kind of like the quick checklist. Whether or not you have a mast cell activation disorder is, again, do you have signs or symptoms of mast cells misbehaving in at least two or more organ systems? Do you get better with medications that target the mast cells or mast cell mediators? And classically, again, we use histamine blockers as an example. And then what test results do you have to show that the mast cells are overactive? So not only do you have markers that may be detected in the blood or the 24-hour urine collections, you can actually go into the tissue where you're having problems and seeing whether or not the mast cells might be chronically activated or not. So just like the nerves, mast cells are found throughout the body, and the figure to the right has shown that mast cells have been implicated in everything from interstitial cystitis to asthma to irritable bowel syndrome, rhinitis, urticaria, and we have a better idea of how mast cells might be presenting in individuals that have connective tissue disorders based on what we've seen in individuals that have a clonal mast cell disorder called mastocytosis, or if they have a non-clonal mast cell disorder. And what was interesting about this study that was done by Dr. Hamilton and his colleagues at Brigham and Women's is they actually looked at individuals that were in a irritable bowel syndrome clinic and asked them, did they have any of the symptoms outside of their GI tract that might point to having a mast cell disorder? And what was really interesting in both the non-clonal mast cell disorders or mastocytosis, which is a clonal mast cell disorder, after the skin or gut, the major issue that was reported by a good number of the patients was neuropsychiatric, that they were having mood disorders, that they were having problems thinking, that they were having memory issues, and they also may have had peripheral neuropathies as well. So the signs and symptoms that are most worrisome for indicating that someone may be having problems with mast cell dysfunction are listed in this figure. So when it comes to the brain, individuals will report a sense of uneasiness, may have increased anxiety, dizziness, confusion, tunnel vision. When it comes to the airway, many people report having throat sensation, that their throat is tightening. They actually may have frank throat swelling, nasal congestion, their nose is running, or they may have lower respiratory distress. When it comes to the cardiovascular system, many people report that they're having palpitations, they have a weak pulse, they feel faint. When the urinary tract, they might feel that they have to go to the bathroom, they might have cramping in the uterus for the women, or swelling in the genitalia as well. Then with the skin, which is probably the most commonly viewed, but I would have to tell you, individuals that have mast cell disorders, not everyone has skin symptoms, but if they do, it's typically hives, swelling, and sometimes you might not have visible skin symptoms. It might just be that you're itchy all the time. So other criteria that leads to mast cell disorder is you have to see whether or not you have, again, two more organ systems. And, when you feel unwell for so long, you might have a tendency to focus on the organ system that bothers you the most, whether it's your gastrointestinal tract or you're having neuropathic issues, pain syndromes, proprioception issues. But it's really important to kind of take an assessment of what else might be bothering you. Like, do you snore? Do you have chronic nasal congestion? Are you having bloating and constipation or food intolerance? You can't maintain a good weight, meaning you can't put pounds on or you can't get pounds off. Do you have joint issues? And this really requires you taking a step back. The old phrase of it's important to kind of not just focus on the individual trees, but look at the forest instead. Then the next criteria that's really important to try to understand is whether or not you can identify factors that are particular to mast cells. And the most sensitive marker for mast cell dysfunction is the tryptase gene. And everybody who has come through an evaluation, they've been told that they have a normal tryptase. But to be honest, the most important thing is to get a baseline tryptase. And then if you have an exacerbation, to measure that tryptase level within 4 to 6 hours of that exacerbation. And a lot of the patients that leave here have a script from me that says, okay, this is a blood test that needs to be run in the emergency department. And then if that tryptase goes from a baseline and increases 2 plus 20%, that actually is diagnostic that your mast cells are much more overactive than they should be. It's also important to kind of check urinary metabolites such as histamine or leukotriene factors. Listed here is prostaglandin D2 or prostaglandin 11 beta F2 alpha. It's really important that once the urine is out of your body, it is stored in a container that is in the refrigerator, and you collect it for 24 hours. And then when you take it to the lab, you need to freeze it right away and send it to a lab that is capable of measuring these metabolites and understand the standards for that. But I have to tell you that the one thing that has been the most helpful in trying to identify a mast cell activation disorder is to go into the tissue and see whether or not the mast cells are either chronically activated, like they've upregulated a receptor saying that they're on alert all the time, or that they have a spindle shape. In the picture I had shown before, mast cells have a tendency to be solitary soldiers. But if they are chronically activated, they have a tendency to be spindle-shaped, not circular, and they also may start aggregating or clustering together. So if you've had an endoscopy, for instance, or a colonoscopy, that tissue is typically kept for 3 years. So you can actually go back and ask the pathologist or ask the physician that obtained the tissue, whether it was in the skin or the gastrointestinal tract, to go back and stain for mast cells. And so in the upper right-hand corner here, you can see that the mast cells have a tendency to be by themselves, and they're circular. But here, in an individual that actually has mastocytosis, you can see that they are somewhat spindle-shaped, elongated, and they're clustered. And that is a diagnostic for someone that has a mast cell activation disorder. Now, just to kind of separate out a histamine intolerance versus a mast cell activation disorder, first of all, histamine is made by lots of cells besides mast cells, so basophils will make it as well. So it is not as sensitive a marker for mast cell activation disorder as tryptase is. But if it is elevated, it is strongly suggestive that your mast cells may be misbehaving. And I wanted to point out the fact that histamine, just like tryptase and the prostaglandins, have various targets which may cause you to become symptomatic. So for Benadryl and hydroxyzine, that goes after the H1 receptor, which can improve or change how your brain is working. It can help reduce vascular leakage. It can cause your heart not to have so many palpitations, and it can actually reduce swelling in certain locations as well. The H2 receptor is located, and most people know it as medications that go after heartburn or gastroesophageal reflux, but that includes famotidine, ranitidine, and cimetidine. And then the H3 receptor, there's no isolated medication that goes after that, but a medication that's commonly used, or used to be commonly used by psychiatrists, such as tricyclic agents, amitriptyline, nortriptyline, which interestingly now is being used by allergy immunology specialists because it helps control hives and angioedema, by neurologists because it helps with headache in some individuals, and then there is the use by gastroenterologists to help with IBS-like symptoms. So this is another way to kind of understand that histamine intolerance may come under a mast cell disorder, but mast cell disorder will encompass lots of different chemicals besides histamine. Typically, what happens with a lot of individuals that have a suspected mast cell disorder, a lot of doctors are not familiar about the fact that you need to measure a tryptase during a mast cell attack in order to try to diagnose it. It's kind of no different than what cardiologists do by measuring serial blood tests to see whether or not somebody's had a heart attack. Not all labs perform these tests, and then it's really important, and some of the things that we've encountered here in New York is to try to get the pathologist on board to use the appropriate stains to identify the mast cells. Now, when it comes to mast cell triggers, everyone is most familiar with allergies, but of the allergic disorders, that's just this one pathway here, which originally was used to fight off parasites or recognize parasites so the mast cells would come in and try to control an incoming parasitic infection. But you can see there are lots of other receptors on these cells, and this is how the mast cells view whether or not there's a dangerous situation in the tissue that they've been assigned to guard. And depending on what receptors are engaged, for instance, we have several individuals that have immune deficiencies, like they don't have enough immunoglobulin receptors. And so this might cause the mast cells to be dysregulated. We have some individuals, women, for instance, when they go in or out of their menstrual cycle, mast cells are known to have estrogen receptors and progesterone receptors, which may be influence mast cell dysfunction as well. So when it comes to mast cell activation, there's lots of different receptors other than allergies or allergic engagement of this receptor that may cause you to release various chemicals, and depending on what chemicals are released is what kind of symptoms you may experience. And so I'm using this slide to just show you that depending on what receptors are engaged, what the mast cell is actually seeing in the tissue, whether it's your nose, whether it's your gastrointestinal tract, whether or not it's your skin, depending on what receptors get engaged, you may have release of histamine and tryptase, or if you go through the toll receptor, which is used to recognize certain bacteria and viruses, you may only have the release of histamine and no tryptase at all. So this is just to emphasize the fact that depending on what receptors are going to be engaged, you may be able to pick up tryptase and histamine as a marker of mast cell activation syndrome. But if you go through a receptor that doesn't use those chemicals, you might miss it. So it's really important to kind of take a step back and have a much more global view of the fact that this mast cell is kind of your first responder on the borders that's exposed to the environment. So if there is a breach in your skin or your nose or your lung or your urogenital tract, it is the mast cell that goes in to see what kind of trouble there is, and depending on what trouble it sees, it will release different chemicals to try to control that danger and call in appropriate help. And this slide is just talking about the fact that mast cells do respond to various, mast cell activation syndrome can respond to various treatments, either giving you partial response or some temporary modest improvement, or maybe actually completely controlling, but it all depends. For the diagnosis, it's really important to try to see whether or not you respond to histamine blockers. Those are the ones that are kind of like the gold standard for trying to see whether or not someone has a mast cell disorder or not. And typically, it's not unusual for neurologists or gastroenterologists or allergy immunology specialists to give you a combination of medications that go after the first receptor, like levocetirizine or Benadryl, and then give you one that goes after the second receptor, which would be Pepcid or Zantac. Leukotriene modifiers, there are 3 different types out there. So a lot of people have heard about Singulair or Montelukast. There's also Accolate or Zafilukast, and then a medication that works a little bit better, but is kind of harder to take because it's 2 large pills that need to be taken twice daily, called Xyluton or Zyflo. Steroids are also very effective for controlling mast cells under certain circumstances, but there's no need to be on a medication like this long term because of all the side effects that are associated with it. The use of traditional Chinese herbal therapy and acupuncture has also been shown to be effective for individuals to try to calm down dysfunctional mast cells. There is a biologic called omalizumab or Xolair, which has been out since 2003, which really has been a game changer for individuals that have just mast cells that are dysfunctional in the setting of either allergies, having allergen-specific tests either to foods or airbornes, or have chronic urticaria along with irritable bowel syndrome, and that there's not another comorbid disorder such as an autoimmune disorder or chronic infection that might be driving the mast cells to be misbehaving. And even when individuals take Zantac and Zyrtec combination, sometimes they don't get any better. And the reasons for that can be one of two in my mind. First of all, most medications have either fillers or preservatives that allow them to sit on the shelf for a year. And those fillers can be milk-based or soy-based, and then the preservatives themselves might be problematic as well. So it's not unusual for some of the patients to have the medications compounded in order to remove the fillers and preservatives and have the ability to just take advantage of the active medication ingredient. The other time that I've seen the combination of histamine blockers or leukotriene blockers not being helpful is the fact that just like the mast cell is guarding your borders, just like this attack dog sees something, you can try to restrain this dog with a leash and a muzzle, but they're still seeing something that they think is dangerous. So it's very possible that the mast cells are seeing something that is dangerous, kind of taking a page from Dr. Theorides' approach, saying that if your mast cells are overactive, it might be a warning sign that something is wrong elsewhere and you need to go investigate. And what I have found is that in a lot of the individuals that have mast cell dysfunction, the mast cells are being called into action by an autoimmune disorder or a chronic infection or possibly an immune deficiency. So to kind of summarize how we find someone may have mast cell activation syndrome or a disorder contributing to their symptoms is, again, do you have the symptoms? Do you get better with medications that target the mast cells? And whether or not you have test results that should support that the mast cells are overactive. It's also important to make sure that there's not another condition going on. And this is a list of some of the conditions that have been shown to be associated with mast cell dysfunction, but is not the mast cell disorder is not the driving issue. It is these other conditions that are causing the mast cells to be dysfunctional or overactive. Once your doctors have assessed whether or not you have a mast cell activation disorder, it's really important to sort out whether or not you have mastocytosis or you have mast cell activation syndrome because something else is going on in your body and causing the mast cells to be dysfunctional. So mastocytosis, generally speaking, is rare, less than 200,000 cases worldwide. And this picture is a little boy that had come to my practice a few years ago, and it was originally thought that the pediatrician originally thought that this was eczema. Actually, it's a collection of mast cells, and this is an example of the biopsy where if you were to biopsy this lesion here or on this gentleman's arm who has lots of little mastocytomas, you'll see a collection of mast cells where they are clustered. They have become spindle-shaped, and then if we were to stain this for an activation marker like CD25, it's very possible that it'll be upregulated as well. So just to kind of review what mast cells are responsible for doing, their job is to be part of the first responders in the border defense, and then they have various sensors to figure out whether or not there is danger there and what kind of danger, and then depending on what receptors are engaged, whether this is going through the Ig receptor, which years ago was recognizing parasites, but now that we have so many things in our environment which has eliminated parasites, but now has exposed us to chemicals that would make the mast cell think that pollen or milk is dangerous. And then after the danger is cleared, it's important for the mast cells to help coordinate the repair. So the mast cells will actually call in platelets and factors from the vasculature to help coordinate the repair and sew up the damage that had happened after the insult has been cleared. So as an allergy immunology specialist, I can tell you that when someone comes in with hives, this has kind of been the one syndrome that has taught me that mast cells can be activated by lots of things besides allergies. So some of the things that I originally look for when somebody may have a suspected mast cell disorder, and especially if they have skin involvement, you want to see whether or not they have sensitivities to certain foodstuffs, medications, or airborne allergens. And then, believe it or not, you can actually develop an autoimmune disorder against your mast cells, and that's called autoimmune urticaria. And typically, there are plenty of standard tests available to see whether or not you've developed antibodies against your thyroid or antibodies against the receptor that's on mast cells that may cause your mast cells to be chronically activated because you have an autoimmune disorder driving the mast cells to do so. There are a lot of other things that can cause mast cells to be overactive. So typically when I see people have chronic hives, IBS, I'm going to be checking for chronic infections, whether it's hepatitis, Epstein-Barr virus, Helicobacter pylori infections. And believe it or not, we do actually pick up some parasitic infections, especially in the gastrointestinal tract. You also want to evaluate for the possibility of an immune deficiency. The most common ones are the ones that are in the antibody compartment. So some individuals may have low serum immunoglobulin, IgG or IgA, or they may have normal levels of antibodies, but they don't recognize what they need to, such as Streptococcus pneumoniae or Haemophilus influenza or tetanus. And that is actually, if you don't address the antibody deficiency or the complement deficiency, it would be very difficult to help the person feel better. We have some individuals that have autoimmune disorders. There's a greater appreciation that individuals that have connective tissue disease or disorders may also be causing the mast cells to be dysfunctional as well. So this means that the mast cells are misbehaving because they're being told by something else in the body to do so. And then every once in a while, and it's very rare, we're actually able to identify individuals that may have a precancerous or a lymphoproliferative disorder because they are having increased symptoms in their skin or their gastrointestinal tract. Just to give you an idea of a growing appreciation of immune deficiencies contributing to mast cell dysfunction, this is kind of the 10 warning signs that comes from the Jeffrey Modell Foundation. And in this setting, sometimes individuals who have primary immune deficiencies, they can have this immunodeficiency go unrecognized for years unless someone takes a step back and asks the appropriate testing to be done. So just to kind of give you an idea of if you have a history of sinus infections or you've had 1 or 2 pneumonias, or if you had Clostridium difficile colitis that's recalcitrant, it's really important to try to assess whether or not you may have deficiencies in other parts of your immune system that is now forcing your mast cells to kind of step up and try to compensate, not as appropriately, but try to compensate as well. So this is kind of a summary of the different testing that I do when patients come through for an assessment of Mast Cell Activation Syndrome or a Mast Cell Activation Disorder. We will do panels looking at common airborne and food allergens. We will review whether or not they've had endoscopies or colonoscopies. We'll check a celiac panel. Very important to make sure that there's not a history of severe infections or recurrent infections. And then for individuals that have physical stimuli, such as change in temperature, pressure, different ways of sunlight, these are individuals that may have a cross-communication within the connective tissue between the nerve fibers and the mast cells that sit next to each other within the connective tissue as well. So this is a slide just focusing on the fact that mast cells can become dysfunctional in lots of different ways. What's most common the least common is having a clonal mast cell disorder called mastocytosis, and these are individuals that have a mutation in a growth receptor that causes the mast cells to kind of disobey the community rules. Then you have individuals that actually have a normal level of mast cells, but they have sustained or acquired a mutation in the enzyme tryptase and have more tryptase. So every time those mast cells become activated in a situation that will cause tryptase to be released, they'll end up releasing more tryptase, or they may even have a basal level of tryptase that might be elevated. So, and I have to tell you, there's an ongoing discussion in certain scientific communities trying to understand what exactly is a normal tryptase. But for the vast number of individuals that have Mast Cell Activation Syndrome, it's being driven by another disorder. And these are some of the disorders that commonly can cause mast cells to become dysfunctional. So when it comes to the treatment of someone that has a Mast Cell Activation Syndrome, you need to make sure that you've identified any other comorbid illnesses that might be driving mast cells to become dysfunctional. So if they have allergens that they're sensitive to, whether it's airborne or food, it's important to do avoidance measures. Consider using medications that target different substances that get released by mast cells, including histamine blockers or leukotriene blockers. There is a role for some individuals to receive immunotherapy, whether it's through injection or sublingual immunotherapy. the use of omalizumab, and now there is another medication out there that targets chemicals that get released by mast cells that has been shown to help quiet down mast cells. It's important to make sure that there's no signs of infections. And when it comes to Lyme, for instance, you need to differentiate the difference between whether or not there's an actual infection as opposed to the fact that you've had an exposure and you become sensitized, because that might not necessarily warrant months of antibiotics to try to help your symptoms come under control. These are some of the common infections that may cause mast cells to be dysfunctional, so targeting treatments to reduce hepatitis, Lyme, Borrelia, Epstein-Barr virus, or herpes viruses are important to kind of address. If you have an immune deficiency or an autoimmune disorder, the use of supplemental gamma globulin products, whether intravenously or subcutaneously, has also been shown to be very helpful for getting the mast cell dysfunction under control as well. So regarding very quickly the link between mast cells, Ehlers-Danlos syndrome, or hypermobile spectrum disorders, or neuropathies or dysautonomia in the form of postural orthostatic tachycardia syndrome, not only do I do review of past medical history, it's also important to kind of just do certain screens to make sure that you're not missing a connective tissue disorder. And so we have part of our questionnaire, we do have a Beighton score, as well as looking for any comorbid illnesses or symptoms that can be associated with somebody that has a connective tissue disorder such as Ehlers-Danlos syndrome. And then with cooperation with neurology and cardiology, we will do an evaluation for dysautonomia as well. Just to briefly review the family that opened my eyes to Ehlers-Danlos syndrome and Mast Cell Activation Syndrome. This was years ago, and I have to tell you, through all the years that Jessica shared about my training, I did not learn any of this until this little boy came into my door. And by the time he was 4, he had all these specialists involved in his care. And really, it's a question of just finding a practitioner who's going to be open-minded and willing and able to learn with you on how to help you feel better. And I think I am going to kind of wrap up here with showing some comments by Dr. Castore back in 2012, who show that Ehlers-Danlos syndrome is definitely more than just a connective musculoskeletal issue, that having the brick and mortar of your body be not well prepared for the current environment can lead to lots of different syndromes, including immune dysregulation. And when it comes to immune dysregulation, I believe it's at the level of the mast cell. This is just a paper to highlight the fact that if you have a tryptase of 8 or higher, I strongly recommend a test that looks at whether or not you have a duplication or a triplication of the tryptase gene. That test is now available in the States by a company called Gene by Gene, and this would be extremely helpful to see whether or not you have mast cell activation syndrome. Of note, individuals that have a duplication or triplication of the alpha tryptase gene have been shown to have mast cell activation syndrome, dysautonomia, as well as a connective tissue disorder that's reminiscent of Ehlers-Danlos syndrome. And the comment that Dr. Theourides likens tryptase to, it really is not just a marker. It actually has a job to do. It loosens up the connective tissue, and he calls it the meat tenderizer. So if you have signs or symptoms of mast cells misbehaving, again, it's really important to see whether or not you have, if irritable bowel symptoms are bothering you the most, it's important to kind of see whether or not you have itchy skin. Do you have a history of anaphylaxis, whether it was intraoperative with an anesthetic or you had shellfish accidentally? You want to make sure that you have the ability, or you've demonstrated some type of response to medications that that cause mast cells to quiet down, or the mediators that they release. That includes histamine blockers, leukotriene blockers, ketotifen, cromolyn, or omalizumab. And then again, what are the test results that are shown to be helpful? Okay, I think that is just to give you an idea of the different symptoms that are associated with this, and I'm happy to try to address any questions after a whirlwind tour of how your mast cells can go awry.
We have a lot of questions. Thank you so much. to start out with, we have a lot of people who are wanting to talk to their doctors about it and aren't quite sure how. So just kind of a summary of the kind of questions we're getting. How could patients bring up the possibility of mast cell activation syndrome? What kind of provider should be seen to run these tests, and what to do if your provider isn't very open to it, and what resources to give them, that kind of stuff.
So, depending, so I would have to say to kind of, the first thing to do is kind of educate yourself. And there are in the States, we have the Mastocytosis Society, which actually has a list of practitioners who have demonstrated a willingness and an ability to listen. And then also it lists the various descriptions of mast cell activation syndrome. So that's one place to start. In order to bring it up to your practitioner, I would have to, it's kind of like moving a mountain in that this is a syndrome that was only given a name 10 years ago. And traditionally, it takes close to 2 decades for a newly identified syndrome to work it into the general biomedical community. So if you feel that your practitioner is willing and open, then I would say there are papers that are available, including in the New England Journal of Medicine back in 2015, to say this is the syndrome, this is how you identify it. Can you please just run these basic tests for me? Check a tryptase, check a serum histamine level, and then you need to be referred out to a practitioner who has experience in doing this. And there are a growing number, but I would start with using the Mastocytosis Society as a suggestion on where you can identify a practitioner. And some of these practitioners who, they might not necessarily be in your state, but they might be able to offer telephone consultations, which they can review your chart and make suggestions to your practitioner to run with this. As far as what specialties, allergy immunology, Lawrence Afrin is a hematologist oncologist. We've collaborated with cardiology and neurologists. There's a lot of crosstalk with other societies, including the Ehlers-Danlos syndrome and Dysautonomia International, where they're starting to show that there is that mast cell activation syndrome should be considered if you're having symptoms and not getting any better with the treatments that you received up to that point in time. I am hoping, I'm actually working on a booklet, and people have heard this before, but believe it or not, it should be out within the next 4 weeks, which will be helpful to help diagnose this. Or at least give you the tools so that you can then have a conversation saying, okay, this is what I've been dealing with. This is what I've been taking. Can you please make a referral to a specialist who may be able to give us guidance on how to get better? So this is all about partnership, and everyone needs to identify a co-captain who is, again, willing and able to help you connect the dots in order to see whether or not immune dysfunction in the form of primary mast cell dysfunction or it's being driven by another process as well. Sorry, that was a little long-winded, but.
Thank you. We have a few questions about testing and about what medication should be stopped or avoided before testing and for how long.
So if you're doing the 24-hour urine collections, I recommend stopping the histamine blockers at least 5 days before if you can. It's really important if you're going to do the 24-hour urine collection and it's being done by a commercial lab that you make sure that you do it earlier in the week so it doesn't sit overnight on the desk before it's properly processed and shipped out. It's also important that when it comes to the tryptase, you get a base level, but then you should get a script from your practitioner. So if you have to go to urgent care or the emergency department and you're thinking you're having a mast cell flare, that they check that tryptase level when you go into the hospital. And that can help you diagnose the mast cell disorder as well. I have to tell you, though, many of the patients that have come through have had endoscopies or colonoscopies, and you should know that tissue typically is kept up to 3 years after you've had a procedure. So it's easy enough, instead of going through that procedure again, is to kind of just go back to the gastroenterologist or the dermatologist who obtained that tissue and go back and stain it. And that is very easy to do, and can be easily paid for through insurance, because now we have diagnostic codes for mast cell dysfunction in order to have that evaluated as well.
Just a little bit of a follow-up to the other, if some people are saying that they have had a normal tryptase level as a baseline, and their doctor is not really open to pursuing it further because they notice that normal tryptase level. Do you have any advice for those?
So there are 2 papers that are out. Then what I would do is, and I can post this later. So there are papers in the New England Journal of Medicine, and the lead author is Theorides. It says in there that it's not just a baseline tryptase. It's a tryptase level, and then you count it within 4 to 6 hours. And then also I would say that if your doctor is not willing, they might be willing to ask, might be willing to provide you with a script or a referral to someone who has expertise with mast cell disorders, and that physician or practitioner can provide you with a script in order to have it checked if there is a urgency. Most patients, after they leave my office, receive an action plan, including a script that is downloaded from the Mastocytosis Society, showing that these are the tests that should be taken if you've been hospitalized or if you've been in the emergency department. And then there's an action plan, and it's a signed script. So typically, having that signed script should be sufficient in order to get that test, and then you could bring it back to the practitioner. But if the practitioner is that resistant to it, then I would recommend a second opinion from a practitioner who's more willing and able to work with you.
If you become symptomatic after a trauma, is it possible to go into remission?
Yes. Yes. It is possible, but it all depends on whether or not what type of trauma, and whether or not that caused remodeling in the area where, or in the organ system where you sustained the trauma. So the question is, are you talking motor vehicle accident? Are you talking an operative procedure? Are you talking infection? All of these things can cause mast cells to go into action if that trauma is resolved, and you no longer have any other comorbid disorders that have been unmasked by that trauma. You can go into a quiescent state. But also understand, if you've demonstrated the ability to have a mast cell activation attack, it can happen again. It's just a question of the next perfect storm that comes along that may open that door.
So this person has said that they have taken steps to reduce their exposure to some of their triggers, but now that they have noticed that when they're exposed to those triggers, they have an even more severe reaction. Are they making themselves more sensitive to the triggers by avoiding them?
Yes. So when it comes to tolerance, avoidance does not lead to tolerance. So that's why we, as allergy immunology specialists, our job is to build tolerance. And that can be done by lots of different ways. So when it comes to certain foods, we will reintroduce it slowly but surely and make sure it stays in the diet and your body remains familiar with it. If it's an airborne issue, there are ways of desensitizing to allergens as well. Interestingly enough, we use medications such as aspirin, even though we tell you to avoid it. But interestingly enough, aspirin has been a age-old medication that's been shown to quiet down mast cells, and has been shown to help with controlling rhinitis, asthma, and also neurocognitive impairments as well, as long as you can tolerate it. So there are various treatment options that are available, but it really is about being prepared, identifying what is going on, what are your triggers, how you can reduce your exposures. But then, if it happens again, is there a possibility of building up tolerance through active desensitization, whether or not that is through injection, whether or not that is through oral or sublingual treatments. And we're now partnering with Dr. Schumann Lee in using acupuncture and acupressure as a way to also induce tolerance as well. So if we can quiet the mast cells down and restore peace in the tissue, yes, you can go into remission. But if another trauma comes along, it's very possible that you might slip down that hill again. And so we've had people that have had prolonged periods of well-controlled immune dysfunction. It's kept at bay. But then, life keeps coming at you. So if you get an infection, if you have a motor vehicle accident, and then you get medications that you shouldn't be getting, it might open the door again, and then we have to work hard to close that door again.
You mentioned aspirin. What was the dosage for that, the recommended dosage?
It depends on the patient. So unfortunately, there's not a standard dose for doing that. So some people respond well to 81 milligrams. Some people we have to take much higher, and that definitely has to be done under supervised conditions because it's kind of like allergy shots. We're trying to calm the mast cells down with what we know can cause them to become excitable. But there are protocols that are used for aspirin desensitization as well.
So what are the long-term effects of mast cell if it's never brought under control? Another question is, what is the long-term prognosis of mast cell activation syndrome?
Well, given the audience for this, what I imagine who's listening to this, if the mast cells are misbehaving because you have an immune-mediated neuropathy or you have a connective tissue disorder, if you can help the connective tissue get better or you can address the autoimmune neuropathy, the prognosis can be quite good. But you have to address what's driving the mast cells to become dysfunctional. So in many ways, mast cell activation syndrome, with the exception of those that have a duplication or triplication of the tryptase gene or have a mutation in the c-KIT gene, meaning that they have some type of gene modification, it is going after what's causing the mast cells to be overactive. And as a person that's had chronic urticaria and rhinitis for years, so in essence, I may have mast cell activation syndrome. I just haven't taken time to take care of myself. I have to tell you that if I'm well and then I find that I have increased hives or I'm having increased nasal congestion, those mast cell mediated signs are telling me something's wrong in me, and I need to figure out what that is. Is it an infection? Did I take a medication? Is it a climate issue? It's the mast cells are acting as like the canary in the mind, saying that there's something wrong elsewhere. You need to figure out what that else is, get that under control, and then the mast cells will stand down.
Have seizures been observed to be caused by mast cell activation syndrome? We've had a few people reporting seizures.
Yes, because if you drop your blood pressure because you have caused the blood vessels to become very leaky, then you will impact the part of the brain that may be susceptible to seizures, or it could be seizure-like. We have seen individuals that have heart attacks from mast cell called Kunis syndrome, where you have localized compromise of the blood flow in the heart, and that can cause your heart to go under attack as well. That's not terribly common, but yes, that has been seen. We've actually seen individuals that have mast cell activation syndrome thought to have multiple sclerosis. So you have this mast cell dysfunction going on in the brain, and then interestingly enough, those MS-looking lesions get better when you start targeting the mast cell activation syndrome and what may have caused the mast cells to become dysfunctional. So, it literally, what I have a tendency to tell patients is mast cells are in every single organ system. So, and the easiest thing to envision is hives, right? So you have localized swelling in this part of your skin. Well, what if that happens in your brain? What does that look like? That could be headaches. That could be loss of function of that part of the brain, like you have problems speaking or you have problems accommodating your vision. What does that look like in the gut? You can have bloating. You can have diarrhea. You can have constipation. You can have gastroparesis. What does that look like in the joints? Well, you could have pain. So it all depends on its location. Where are these mast cells misbehaving? What are they releasing that's causing you to have issues? And so pick an organ system, just like the one that you're seeing right now. Depending on where those mast cells are misbehaving and what's causing them to misbehave, you can have those symptoms and signs.
For people outside of the United States, particularly Canada, which is the one that was featured in this, are you open to consult requests, or how does that work, or how would you recommend people out of the United States find a practitioner or the correct medical care for this?
So there is a Mastocytosis society in Canada. There are immunology specialists that I know have shown interest in that as well. We actually have had patients from Canada come here, and I have had telephone consultations with patients that are in Canada as well. So there are various options. So the first thing would be to look at the Mastocytosis Society that's in Canada and see what practitioners that they have identified. Second would be Dr. Vadas, who is an allergy immunology specialist, I believe, who's in Toronto, has expertise with Mast Cell Activation Syndrome in the context of connective tissue disorders as well. And then, yes, I am open to telephone consultations. The information for that is on my website.
So this is kind of overwhelming for a lot of people. How do you figure out what is wrong with us when there seems to be so many triggers going on at once? How do you focus on one and pare it down and figure out what to deal with and in what order?
So if you were to look at if you go to the website and look at the new patient questionnaire, it's like 18 pages long. And so you really have to kind of go, and so it's kind of a systematic approach. What are the symptoms that bother you the most? When did it start? And understand that, again, this is a question of a partnership. So let me figure out what bothers you the most. Let me figure out whether the mast cells are primarily causing the problem or something that's causing the mast cells to misbehave. So we start with the history. And you'd be surprised. I didn't show you. I'll give you an example. I had a woman, before I had an electronic medical record, come to me because she had chronic hives. And her hives were really difficult to control, but with a combination of different medications, including a prophylactic antibiotic, she came under better control. What was interesting is when I got her electronic medical record, I saw that she was getting antibiotics and steroids from another practitioner every 3 months. And I'm like, why are you getting this medication every 3 months? She's like, because I get asthmatic bronchitis every 3 months. So I went ahead and said, okay, let me see whether or not you have a primary immune deficiency. And as it turns out, she had low IgG, low IgA, and low IgM. And then I went ahead and did the mast cell studies, and she had a tryptase of 11. So she had 3 different things, and she also had an autoimmune disorder. So she actually made antibodies. She had thyroid antibodies that were also driving her mast cells to be misbehaving. So she had an autoimmune urticaria, an autoimmune mast cell disorder. She had common variable immune deficiency, which is it's probably the most common antibody deficiency that's found in children and adults. And she had an elevated tryptase level, which means every time her mast cells were tickled a certain way, she released twice as much tryptase than she should have. So her treatment, which got her under control, was she went on subcutaneous immunoglobulin therapy for a primary immune deficiency. She actually went on to Xolair for her autoimmune mast cell disorder, and she was on a cocktail of histamine blockers for her hypertryptasemia. So it was, okay, what do we do to treat the allergies and the food sensitivities? What do we do to treat the immune deficiency? What do we do to treat the allergy, sensitivities that you have, whether it's food or airborne? What do we do if you have an autoimmune disorder? And then regarding the connective tissue issues, believe me, I partner with physical medicine and pain service, as well as neurologists, to make sure that there's not something going on with the connective tissue and the nerves. So you really kind of have to do it step by step and identify what might be potential triggers of the mast cell dysfunction. And literally what I just shared with you in the past 40 minutes has taken me 10 years to kind of just try to understand how these mast cells are misbehaving. And I actually had to relearn mast cell biology because I'm a T-cell biologist by training. And we have a tendency, for instance, even rheumatology, and Dr. Graham has pointed out how rheumatology has somewhat underserved the Ehlers-Danlos connective tissue disorder community, and they focus on antibodies to see whether or not you have an antibody against rheumatoid factor or against nuclear antigen. But I have to tell you, in order to get to make those antibodies, you have to go through the mast cell and the connective tissue, the part of the innate immune system. And we're just starting to learn how to look at the innate immune system. And the information is slowly getting out there. But it's really, really important that you kind of partner with a doctor who's going to be open-minded and willing to listen to you. And if that doctor is not willing or is just in a system that won't allow them to do so, then you might have to invest on going outside of that system and getting another practitioner who's willing to put their name next to, this is what I think is going on, and here's how you can help, and digest it down to them in a way that they're willing to kind of open their mind and partner with you. And if the person is really that, dismissive, then you need to find somebody else.
Thank you so much, Dr. Maitland. It is about that time. We had so many questions today. We didn't get to that many of them, but I think that we all learned a lot. We've gotten a lot of feedback from people just saying thank you for such a great and informative webinar. So thank you so much. You
My
mentioned
pleasure.
that you have a publication coming out soon. Where will this
Yes.
be available?
So it's going to be an online. I think I'm going to be kind of just using either Amazon or this other in order to kind of, and I'll put the link in on my webpage and my website for the practice. And also I have just spoken with the person who runs the New York City chapter of Ehlers-Danlos syndrome, and he says he's more than willing to kind of sponsor a webinar there where I'll have the books available there too.
Great, and you can send that to me as well, and I would love to post it on the Ehlers-Danlos Society's social media, so you can look for it on Facebook on our page as well.
Yes, ma'am. Thank you.
Thank you. Well, that is all the time we have for us today. If you came in late or just want to watch this again, this webinar has been recorded. It will be on our social media probably early next week. So thank you all for attending and have a great day.
Thank you. Enjoy the day. Take care.